All right, hello everybody. So it's 6 o'clock now. I'll just give a couple more minutes for people to kind of stroll on in. But thanks for joining this webinar. My name is Samuel Koo. I'm the shoulder specialist that be giving the talk tonight. Just want to thank you for coming. Um, and I guess I'll also take this time to thank IRG for sponsoring this. Thank you guys. Thanks for setting this up. Appreciate it. And again, we'll get started in about a minute or so. Okay. So without further ado, let's talk a little bit about shoulders. So I'm a shoulder surgeon. Obviously, I trained as an orthopedic surgeon, but my decision was to focus my practice and my training specifically on the shoulder. And so that's really all I deal with. I don't deal with anything else. And today, in particular, we're going to talk about shoulder arthritis. What is shoulder arthritis? What causes it? What do people deal with? What kind of options are there to treat it? And so we'll kind of go through some of those things today. All right. So, like I said, my name is Samuel Koo. I am a surgeon at Proliance, Proliance Surgeons. We are located in the Kirkland area for my specific office. It's called Pro Ortho. And as I said, I just treat shoulder patients. So I grew up around here, and so I went to Shorewood High School in Shoreline. I don't know if any of you guys are from there, but that's where I did. I went to high school, and after high school, I spent a considerable amount of my time in the Chicagoland area, so in Illinois. So I initially went to Wheaton College, which is a little suburb west of there. And after that, I went to Northwestern in the city to do my medical school training. And then I stayed at Northwestern for my orthopedic training. And then, like I was describing before, I was especially interested in minimally invasive shoulder surgery. And so I did my shoulder fellowship with a guy named Steve Burkhardt, who is widely recognized as one of the top 2 or 3 surgeons in the world when it comes to minimally invasive shoulder surgery. So I had the privilege of doing that with him in Texas. And then I made my way back to Seattle because it's where I'm from. And I've been practicing since 2009. So when you talk about the shoulder is I mean, the reason I chose this whole shoulder, it's a very interesting joint. We sometimes joke as orthopedic surgeons is that the knee, very simple joint, basically it bends and it extends. But the shoulder, interestingly, it has a number of motions. It's really not a very constrained joint, meaning that the ball and the socket, if you just kind of left the bony structures together, they really wouldn't have any stability. It's like having a golf ball and a tee. If you kind of push it, it just falls right off. And for the shoulder, a lot of the function that comes from that contributes to its function is from the soft tissues, things like the rotator cuff, things like the ligaments that support it, like the biceps. And that's a combination of all those things is what makes shoulder such an amazing joint that allows people to move it in a variety of directions throw a baseball over 100 miles per hour for some. Um, and it is a fascinating joint. But because of those things, and because the shoulder is an amazing joint that could do a lot of those things, there's a lot more opportunities for injury. And so it's a little bit more of a delicate body part that requires a lot of things to go right. And so when you consider the shoulder anatomy, that's what makes it so interesting. That's also what makes it more vulnerable to injury. So what is arthritis? I know a lot of you guys either have it or have friends that have had it. And essentially what arthritis is that there's damage to the cartilage that line the joint. So every joint has what we call articular cartilage that line the joint. And it's, if you've ever eaten chicken at KFC before, if you kind of look into the joint, you see the shiny silvery or whitish lining to that joint. And that cartilage is what imparts the natural um, fluidity between the joint surfaces that allow the joint to glide with each other and allows the joint to function like it does. Arthritis is a disease that attacks that cartilage so that that cartilage thins, and it actually thins to the point that it goes right onto the bone. And so the cartilage disappears, and then now you got bone on bone disease, and that's what we call arthritis. And clearly there's different stages of arthritis, right? You can have small amount of arthritis all the way to what we call end stage arthritis, where all the cartilage is gone. Now you're just bone on bone. And that's what causes a lot of the impairments and problems that you see in the shoulder or in any joint with arthritis. The way that you diagnose um, arthritis, and probably the best way and a very convenient way, is through x-rays. X-rays are simple things that can be done at any orthopedic office. And if you come to see any one of us at our office, we have an X-ray available and we get it done right now, right there and then. It is all digitized. And this is kind of what you might be looking for in a shoulder X-ray for people with arthritis. You see incredible deformation of the joint. Typical joint is very round and there's space between the joints, but you can see in this X-ray that there's hardly any space in the joint. You got big bone spurs, and these spurs form for those who are more mechanically inclined because there's a lot of stress within the joint itself. And what the body does at that point, because of the excessive stress in the joint, it creates a bigger surface area for that stress to be distributed. And that's why you get these bone spurs, because it increases the surface area through which that force can dissipate. And so that's what causes the bone spurs. This is kind of what arthritis looks like. Outside of an X-ray, best next advanced imaging to further evaluate shoulder arthritis is through a CT scan, a CAT scan. So CT scans are incredibly useful to look at bony structures. And again, with people with really bad arthritis, like this particular patient, where there's a lot of bone loss in the socket, it can be incredible preoperative tool to diagnose really bad arthritis. And it can also change kind of how we approach treating these type of patients. You've heard of MRIs. MRIs are a little less helpful at looking at the bone, but nowadays the MRI has gotten so good that sometimes nowadays, instead of exposing people to unnecessary radiation with the CT scans, I just order an MRI because that gives me at least a pretty good idea of how everything looks. And the MRI has the added benefit of being particularly good at looking at soft tissue structures. So, whereas the CT looks at bony structures pretty well, MRIs are absolutely fantastic at looking soft tissue structures, and structures such as the rotator cuff, which I'm sure a lot of you guys heard about, uh, things like the labrum, the biceps, even the articular cartilage and in arthritis, and seeing loose bodies within the joint. The MRI can be incredibly helpful with that as well. And so shoulder arthritis, uh, the first thing, people come and talk to me about is, what do I do? I have a lot of pain. How can I manage it? I have trouble sleeping, right? That's a big component to a lot of people's issues with shoulder pain. And there's a lot of options that you can consider. Some of the conservative or non-surgical options, clearly one of them is lifestyle changes. So if you're a super active person or you like to lift heavy weights and you do a lot of weightlifting or weight training, a lot of people may not like to hear it, but lifestyle changes where you kind of decrease the amount of activity or stress that you put on the shoulder, or even if you're a weightlifter, even if you decide not to stop it completely, some of the things that you can do is to decrease the weight so you're not maxing out, increase the reps so that you're keeping the muscle tone. And so lifestyle changes, I think, is a viable way to at least help yourself for the short term. Physical therapy, I think, is also a fantastic way to attack shoulder arthritis. And the idea here is that the pain that's caused by arthritis is by the excessive force and pressure that exists within the joint. And when you have decreased range of motion because of arthritis, it just exacerbates that pressure. And what I like about physical therapy for shoulder arthritis and what I prescribe is to work on the range of motion as much as you can, because the better range of motion that you can sustain in the face of shoulder arthritis, the more likely you're going to have success in trying to keep pain free and prolong the time before you'll need any type of treatment. So physical therapy, range of motion is the number one thing that I'm looking for there. Medications, anti-inflammatories, right? Whether it's Advil, Naprosyn, Aleve, any of these over-counter medications, they can help. It's kind of a trial and error thing. How much it helps some people a lot and others not as much, but certainly that can play a role. And then injections, many of you hear a lot about injections. Cortisone injection is one very common one. Although I have to say, I have been moving more and more away from cortisone injections. A single injection in general is fairly safe, but over time, multiple injections can cause softening of the tissues and of the bone, and I don't like that. And there's been a lot more recent literature to suggest that if you have cortisone injection within a year of having a shoulder replacement, your chances of infection go higher. And that's true for not only joint replacement, but even arthroscopic surgery. So if you've had cortisone injection within a short time, you undergo shoulder arthroscopy, your chances of an infection go up. Not only that, your chances of surgical failure also go up as well. And so for that reason, I've been shying away from cortisone injections unless there's really not any other better option. PRP is another option that's available, and that stands for platelet-rich plasma. I'm sure a lot of you guys are familiar with it because it's kind of all over the news, and it's another alternative that's been out there. PRP in particular has been around for several years. It's been used in professional athletes to help them get back into sports quicker after an injury, right? Help things with like tennis elbow, muscular injury, now arthritis. And while it is technically still experimental, there are studies that are out there that suggest that in comparison to some other treatments, such as cortisone, it can be actually very efficacious in treating certain types of issues. And in my experience, shoulder arthritis may not be a bad one to treat with PRP. And so I think that still is a viable option for those who are looking for maybe more of a natural way to go about it, who may want to avoid cortisone injections or have had trouble with cortisone injections in the past. I think PRP injections is a very viable way to move forward with that. So these are some of the non-surgical options that you can consider. The next step in treatment After that, if those things just haven't worked, would be arthroscopy. And so arthroscopy is the minimally invasive technique where we put a camera inside your shoulder to take a look. And there's a lot of different things that we can do. So these are some HD images from an arthroscopy. It magnifies the joint 4 times so you can see the joint very clearly. And here the white ivory kind of joint lining is the cartilage itself, and the yellowish hue to that part of the screen is the bone. And so you can see where the cartilage has eroded and you have bone, and that bone on bone looks something like this. And for certain patients who are younger, who have just focal disease, meaning just kind of arthritis in just parts of their shoulder, not all parts of their, and not the whole joint, you may be able to go in and just kind of debride it or clean out that joint. It doesn't solve the arthritis problems, but it can help the mechanical parts of your shoulder issues for a while. So if you had like a loose piece floating around in your joint or a cartilage flap that might be causing some mechanical issues, those are things that this type of surgery can help in. So just the cleanup. But nowadays, we have become a lot more facile in what we're able to even offer arthroscopically. That not only can you do like a cleanup or debridement, but now you can do something like this, where it's we call it an interpositional arthroplasty using a dermal allograft. That's just fancy word of saying you take this dermal allograft, and on the screen's left-hand side, you see that kind of rectangular piece of tissue. That's a cadaver tissue. It's a 3 millimeter thick cadaver tissue that we can actually sew onto the socket so that it remains as a cushion between the ball and socket. And this is all done through small arthroscopic portals. And for a very select group of people with early arthritis, so younger patients with arthritis, patients that you might consider them a little bit too young to undergo a full shoulder replacement, this may be an option that you can consider. And I've had several patients that have benefited from something like this and had avoided having to have a shoulder replacement at least for a few years. And so this is another option that's available arthroscopically. Really, in terms of kind of long-term solutions or things to kind of permanently get rid of the arthritis, the only option is a shoulder replacement. And, it's really funny because replacements of joints is extremely common. So if you look at hip and knee replacements, which are the most common type of replacements that are out there, and I'm sure all of you guys have someone that that have had a hip replacement or a knee replacement, because just in the last year alone, there was probably about 1 million of these done in the United States. 1 million total hip and total knees replacements done. By comparison, shoulder replacements are a lot less common. So about 55 to 60,000 of these are done in the United States compared to the knees and hips. So they're not as common, but they are certainly being done. And these are the type of shoulder replacements you can do. One is a primary total shoulder replacement. Second is a reversed shoulder replacement. And those are the two primary ones I want to talk about today. So in general, these shoulder replacements, just like their counterparts in the knees and hip, are very safe, they're very reliable, and they're very effective in helping people get back to a more functional lifestyle. So there are multiple studies that look at this, that compare the reliability of shoulder replacements to a knee or hip, and they're very equivalent. And the best thing that joint replacement do, and the shoulder is no exception, is that it helps to alleviate the pain. So if you have pain associated with an arthritic joint, a joint replacement is going to help you quite a bit with that. So let's talk about the first type of shoulder replacement. primary total shoulder replacement. This used to be the most common type. And I think when most of you think about shoulder replacement, this is probably what you think about, right? Where you replace the ball and socket of the shoulder joint with a metal and plastic piece, right? And in the case of a primary total shoulder replacement, the way we go about doing that is that we replace the humeral head, or which is the ball part of the socket, with a metal stem and head prosthesis. And then we replace the socket portion with polyethylene, or it's a plastic component. And that's what comprises a total shoulder replacement. And in the past, this used to be the most common type of shoulder replacement. And this is, how they look like. You can see on these pictures that you have a humeral head, or the ball portion of it. You have the stem that extends down the humerus, which is the shoulder bone. And the socket side, which is plastic, which you can't see often. Nowadays, we are becoming even more better at preserving bone, whereas the stem used to extend very long and deep into the humeral bone. Nowadays, they become shorter and shorter, and you can see the picture kind of right in the middle inferior part, where there are stemless implants now that are available if you chose to do that. And that's kind of, again, the wave of the future. Again, less metal and more bone preservation is generally the theme, although I think the standard today would still be like an implant that you see in the upper right. That is contrasted to what we call a reverse shoulder replacement. And I'm sure a lot of you heard about that. And what's reversed, or why it is called a reverse total shoulder replacement, is because whereas in the primary total shoulder replacement, you remember that we exchanged like for like. So where the head used to be, we put a metal head. Where the socket used to be, we put a plastic socket. In a reverse total shoulder replacement, we do exactly the opposite. So again, where the head used to be, you no longer put the head, you put a socket component. And where the socket used to be, you put a head component. And the reason that you would do something like this is because of the anatomic restraints that you have with certain patients. So for a total shoulder to work, so a construct like this to work, what you need is just arthritis in the bone, but the rest of the structures to be intact, meaning the important structure being the rotator cuff. The rotator cuff has to be in good shape. If the rotator cuff is not in good shape, you cannot do a primary total shoulder replacement. A reverse total shoulder allows you to perform a replacement of the joint even when the rotator cuff is not in good condition. And that's why nowadays this has been offered for the last 10 to 15 years. First, it has started in the European countries, and then it migrated over here. And nowadays, the reverse total shoulder, when you talk about volume, it out volumes the total shoulder replacement. So it is the most common type of replacement that's done in the United States. Although the exact figure is not quite known, most people think that it's about a 60 to 40 split, where more reverse shoulder replacements are done compared to a regular shoulder replacement. The reverse shoulder replacements also are used in a lot of different applications as well. So in addition to arthritis and in addition to rotator cuff problems, when you have revision cases, so where a primary shoulder has failed, a reverse total shoulder replacement is a good revision type of replacement that you can conduct. And in cases of very complicated fracture of the shoulder area, a reverse total shoulder replacement can also help in those situations as well. And again, just more indications coming up for this particular type of prosthesis. So this is just kind of a review of what we talked about for reverse total shoulder replacements. And because it's a little bit more of a newer type of prosthesis, there's a little less known about it compared to a regular primary total shoulder replacement. But the outcomes have improved significantly. We are um, uh, uh, further into knowing how these things work, and there's been redesigned prosthesis to the point that there are very good outcomes, at least in the medium term, so the 5 to 10 year area. And the data for anything longer than that are just kind of rolling in, and we're learning more from the European experience because they have had this longer than we have. And so when you look at an x-ray, this is kind of how it looks. So compared to what a total shoulder looked like in the past, this is what a reverse shoulder looks like. So you have the ball where the socket is, and it is held by metallic screws that go into the socket. And then you have the socket where the ball used to be. And this is what a reverse shoulder looks like. And then the way that the reverse shoulder works is that because you don't have the regular rotator cuff muscles to help fire and give power to your arm, it utilizes the bigger muscles of your shoulder, mainly your deltoids, to again raise that arm up and give you function and power. And shoulder replacement devices come in all shapes and sizes and forms, and they continue to evolve. Um, And at least for the primary total shoulder replacements, we talked about the longevity and how long they last. The survivorship is at about 90% at 10 years and 80% at 20 years, which is very comparable to any hip and knee replacements. And so the, um, the science on them are quite good at this time. As we talked about, as far as these shoulder replacement goes, the movement is towards kind of more bone preservation um, and less metal use, and that is here. And again, we're tending towards again more minimally invasive techniques, and I'm sure that there'll be further advancements as we kind of study these and study how to better do these into the future. So thank you very much. This is kind of what I wanted to share with you guys in terms of um, shoulder replacements. I will go ahead and answer some questions from the audience. And so feel free to use the question and answer um, tab to write some questions, and I'll do the best I can to answer them as much as I can. So here's a question. There's a question about, has there been any progress in creating synthetic cartilage? Um, and so, yes, so there are a variety of companies that are into making synthetic cartilage. Essentially, what has been done is that there are procedures, particularly in the knee, where you can harvest your cartilage, then it is kind of um, harvested and then grown in a lab to a sufficient degree that you can actually reimplant that into that defect. And so there are processes in which that is being done in the knee. And again, these are for very specific type of conditions where you have a focal defect, meaning it's not the whole joint that's arthritic, but just a portion of it that's arthritic, a small portion that you can sometimes do this with. And so that is still an ongoing research area in orthopedics. But it's very clearly limited to, again, just kind of partial injuries into the joint. So for people with kind of more global arthritis or general arthritis all throughout the joint, there's really no way for us to put the cartilage back at this time. All right, so there's another question about cortisone injections. Had cortisone injections after surgery. Should I be concerned? again, as I said, I've been moving more and more away from cortisone injections just because of, the reasons I stated before. But I mean, they've been used for years and years, right? And so there is a utility to them. And when used judiciously, they can be very helpful. And so in the setting of after surgery, there are also specific times where that can be helpful, but it sometimes just that depends on some of the details related to the surgery. There's some questions about recovery time after surgery, after a shoulder replacement. In terms of recovery, what I typically tell patients, it's a 3 to 6 month recovery. And that is something that I maybe I'll take a little bit of time to kind of discuss the process of the shoulder replacement recovery and the surgery around it. Um, some of you may or may not be surprised to know that shoulder replacement is an outpatient procedure now. So whereas in the past, many of us used to do this only as an inpatient, meaning you get admitted to the hospital and you stayed in the hospital and you get discharged after a day or two. Today, most of my patients go home the same day, and that's typically the plan. And so the surgery itself takes about an hour and a half. And as long as you're recovering well, which we uh, would normally expect, we expect you to go home. And most people are able to go home and they're happy to go home. Some of the anesthetic techniques that we use today are, I think, significantly superior to what we used before. We use a combination of peripheral nerve blocks, which help to manage the pain for both during the surgery and after surgery. And for those who do get these kind of peripheral nerve blocks, it can decrease the amount of pain medications or anesthetic that is required for the actual general anesthesia. That's helpful for obvious reasons, but then also decreases your need for pain medications afterwards. And so a lot of these kind of advancements in perioperative protocols, I think, have helped people recover a lot faster than they used to. I generally say it's about a 3 to 6 month recovery time. It takes about 2 to 3 weeks for the incisions to heal. I send people to physical therapy about 2 to 3 weeks after surgery to work on their range of motion first. And then eventually we work on strengthening when it's time to do so. I think people also find it a little bit surprising to hear that when you compare like a shoulder replacement to a rotator cuff repair, my experience and most of my patients' experience have been that people with a rotator cuff repair have a harder time. It's more painful. It just takes longer than people with a shoulder replacement. And when you even compare people with the regular primary shoulder replacement compared to a reverse total shoulder replacement, people with a reverse shoulder replacement end up also recovering fairly quickly as well. It's pretty interesting because, when you consider the surgery, most people kind of think it's kind of a gradient from an arthroscopic procedure all the way to a reverse. But it's kind of funny that the reverse shoulder patients end up doing so well. Oftentimes they're kind of a lot more functional and pain-free much sooner compared to maybe some of the arthroscopic cases can be at times. Um, there's some question about stem cell procedures. I don't have much experience with stem cells. I do with PRP, and stem cells obviously is an evolution along that path. My general opinion about stem cells, though, at this time, given my knowledge of it, is that there's just not enough data to suggest that it is superior to PRP. So I'm sure that there will be some application that it's going to be very worthwhile doing, but I just don't believe that there's enough evidence to suggest that we are at that point right now. And given its cost, orders of magnitude above a PRP, for the most part for shoulder arthritis, my preference has been to do a PRP. And even within the PRP family, there's different ways to prepare that PRP. So once you harvest that blood, you can separate the different components of the platelet differently. And in general, my procedure or my preference for the way I prepare the PRP is to go what we call leukocyte poor, where you don't have a lot of inflammatory cells. And so I think that's my, again, that's my personal preference for doing that type of uh, platelet or platelet-rich plasma procedures. Okay, so I'm going to continue down with some of these questions. So there's some questions about frozen shoulder and as it relates to the arthritic shoulder. Um, it's a little bit of a broad question. Frozen shoulders are extremely common, and I see it quite often. And interestingly enough, a lot of times when I see frozen shoulder are at the turn of seasons. So, you know, when it goes from kind of fall to winter or from winter to spring, spring to summer is when I see a lot of them. Um, and it's an entirely separate disease category from, say, like the arthritic shoulder, and it is not a precursor to arthritic shoulders. It's very different. Um, so here's another kind of a question. There's a question about your age and when recovery is more difficult. So that's a great question. So for shoulder arthritis, the patient population tends to be a little bit older than they are for knee and hip. If you look at the average age of patients who are getting knee and hip replacements, they're in general lower in age than they are for shoulders. Having said that, there's no kind of age cutoff, meaning just because you're at a certain age doesn't mean that you're not eligible for a shoulder replacement. I think clearly as you get older, it's in general, the recovery tends to be slower, but patients and people's body are very individual and very different. And so I'm sure you guys know a lot of younger patients who are incredibly sick. And you also know a lot of older patients who are amazingly healthy. And so uh, I think if you put it in general terms, yes, the older you get, recovery gets a little bit slower, but people can recover after a shoulder replacement at any age. Okay, so I'll answer a couple more questions here. So here's a question from a patient. Is it possible to differentiate between a rotator cuff tear or a rotator cuff issue and arthritis? And in general, yes. That's where these diagnostic tests become very important. So as we said, if you come and see an orthopedic surgeon regarding your shoulder, typically we start off with an x-ray. The x-ray will be very clear as to whether you have some arthritis or not. And if needed, we will further investigate that by ordering an MRI to take a look at your rotator cuff. And typically, the MRI is very good at looking at the rotator cuff and the soft tissues so that it's not equivocal. You're not guessing at it. You'll know exactly kind of what you're dealing with. All right, so this is another great question. So the question is, can you talk about what to avoid when trying to make your shoulder joint last as long as possible so as to avoid surgery? So yes, so as we talked about before, um, my general rule of thumb when it comes to kind of non-operative treatment is to do everything that you can to maintain your range of motion. And so if you can try to maintain your range of motion as long as possible, that's something that you're going to be successful at trying to delay surgery as much as possible. This is also a good time maybe to talk about, kind of when is the right time to consider surgery as well, because I get that question a lot. I have arthritis in the shoulder, it hurts, but when do I do it? When is the right time? And if you look at kind of the outcomes for shoulder replacement patients, it's very interesting to find that the better that your shoulder is functionally, meaning the better range of motion you have before surgery and the better function that you have with that shoulder before surgery, that makes your after surgery function even better. So the better you are before, the better you'll be afterwards. And the converse is also true. The worse you are before, the worse you get to be afterwards. And so for the shoulder, this is particularly true. I know for the knees and hip, a lot of times doctors tell you, wait until you can't deal with it anymore. And that's when you should consider doing surgery. But for the shoulder, I think I tell you a little bit, maybe a different message on that is that if you're going to err on the side of being a little bit early versus a little late, at least for the shoulder, my recommendation is side on the being early side, mainly because what we just talked about. Because if you wait too long, you can potentially compromise your results, your functional results afterwards. And although we didn't talk about this specifically within the talk, if you wait too long, you can end up having a lot of bone loss in the socket. And it can come to the point where you have so much bone loss that you will lose your ability to get a regular shoulder replacement. And so your options for treatment can be limited the longer you wait. All right, I'll answer two more questions. Um, let's see. Okay, this is another common question. So where is the pain felt when you have a rotator cuff issue? So this is also a very good question because a lot of times when people have pain in the shoulder area, sometimes it's difficult to know whether it's coming from your shoulder or from your neck. And in general, when you have a true shoulder problem, your pain tends to be in this area. So almost every time when I ask patients, where is your pain? If you have a shoulder issue, most people will kind of grab their arm like this. For those who have pain kind of in this area, like here, there you worry more about having maybe more neck issues. And so that's not a foolproof way of finding it out, but it's a good general rule of thumb that shoulder problems tend to refer down into this region, in the deltoid area, and neck related problems tend to refer more into this area. Um, let's see. So one last question I'll answer is, again, how long do replacements last? I kind of had a brief uh, mention of that. And in terms of survivorship is kind of how we look at it. How many shoulder replacements are still intact at 10 years? 90% is what's intact for shoulder replacements. And then even at 20 years, it is 80%. And this is for a primary total shoulder replacement. The data for reverse shoulder replacements are coming, but at the medium term, 5 to 10 years, they are improving. And so I think, once we have that information, of course, I'd be happy to share that with you. So, Thank you so much for coming to this webinar. Hopefully it's been beneficial to you guys and you learned something about shoulder arthritis. I'm sorry I wasn't able to get to all of your questions, but I'll be doing another one of these in the future, and hopefully more of your questions can be answered then. At future webinars, I'll probably focus more on minimally invasive techniques or arthroscopic techniques, and touch on other uh, common rotator cuff issues, frozen shoulder issues, labrum, and dislocations. And so we'll look forward to seeing you in those kind of in the next meeting. Okay. All right. Thank you guys. Thanks for being here. Have a good night.